Medical Mondays with Dr. O, trying to balance it. And I agree, I get it. Yeah. So we'll be starting in a minute. Welcome. Welcome to Medical Mondays with Dr. O. It's another Monday, and it was breast cancer month last month, October. We focused on domestic violence because it was also domestic violence month, and we took off 2 weeks for needed activities. And so we did not want to miss out on breast cancer and the discussion of breast cancer, the importance of knowing about it and knowing what to do to avert it and also to intervene in case it does occur. And so that's why we're having this talk today. And I want to thank our special guest today, Dr. Sangodeyi. I met Dr. Sangodeyi through Dr. Habatoye, who is family here at Medical Mondays with Dr. O. And Dr. Sangodeyi will become family today since, is now here. I was going to introduce hugely and all of that, but I'll just say that he's the owner and president, CEO of MedSurg Physician Group in West Virginia. And I will leave the rest of his introduction for him to complete. And without much ado, Dr. Shogundeyi, thank you for accepting my invitation and welcome. You have the floor.
Thank you very much, everybody. Thank you, Dr. O. Dr. O, yes, always told me to get involved with this program many months ago, but I finally got an invitation from Dr. O, and I'm gratefully accepted the invitation. Since I'm going to be joining the family, I may very well be the grandfather of this group, since I'm probably the oldest among you all. So greetings to all of you. Today, I have a special topic that is dear to my heart, is cancer of the breast. We're just going to do a brief overview. Cancer of the breast, such a big topic that there's no way to cover it in 20 or 30 minutes, but I'll do my best to just talk about it. By the end of the talk, we want everybody to know that cancer of the breast is no more a death sentence like we used to say, at least in this part of the world. In the so-called developing country, it is still a major problem just because of late diagnosis. And let me just also reiterate that yes, October is the month devoted to breast cancer, but all month, every month should be Breast Cancer Awareness Month. That is just the fact it should be. And I should also tell you my view about healthcare. I always believe good healthcare is the right of everybody. Obviously, a certain part of the world doesn't see it that way. But just not to digress too much, my topic is breast cancer. I'm a surgeon here in Berkeley, and I do a lot of breast surgery and take care of a lot of breast diseases. So next slide, please.
So I'm going to put fantastic.
Okay,
Can
good.
everybody see the slide?
Yeah, I could say it, but it's
Okay.
not. Okay, good. That's good. It is good. Well, breast cancer is a very common cancer. In United States, one out of eight women will develop cancer of the breast in their lifetime. Okay. Now, not only women develop cancer, you also have male cancer, but it's only like 1% of the total breast cancer population. Unfortunately, in certain part of Africa and Central and East Africa, especially in Tanzania, male cancer is actually up to 6% of the total population. We don't know the reason for that right now, but there's some concern that liver diseases increase the estrogen level that can cause the explanation. But mainly, most of the breast cancer is in women. I repeat, 1 in 8 women in US will develop breast cancer in their lifetime. So this is very important. It is a very common cause of death in the US. Globally, we have at least 2 million cases of breast cancer every year. And then the death rate in US is about 40,000 deaths every year. We have close to about 300,000 cases of breast cancer in the US every year. Next slide, please. Now, my first sentence was that people should not be scared of breast cancer. In the olden days, we used to say, you have breast cancer, it's a death sentence. I have patients that I've operated on 40, 30 years ago with breast cancer, and they're still living full life. Why has this death rate been decreasing? It's because of improved screening, and adjuvant therapy improvement, and early diagnosis and early treatment. Like any cancer, most cancer, if you diagnose it early, the chance that you will have a good cure rate is very high. Same thing with breast cancer. In the so-called developing country or third world, I hate to use the word that, but that's just the way it's saying in the medical literature. Diagnosis is very delayed. I remember when I was in Maiduguri or Ife University, people will present with breast cancer that is fungating, very advanced stage, cancer spread through their body. But in the Western world, we have improved screening so that we can diagnose breast cancer at the early stage and treat quickly.
Oh, and shit.
Am I hearing somebody talking at the background? All right. So early treatment, early diagnosis, and improved treatment has
Dr. Ajagbe. I think that's Dr. Ajagbe.
Okay, are we having some problem? Right. I will just continue to talk over that. So death rate has been decreasing in the Western world, but in the developing country, we still have a long way to go because we don't have all the technology to improve screening and early diagnosis. So people present at a very late stage. Next slide, please. Now, how do we diagnose breast cancer? Obviously, self-breast exam is very important. People examine their breast and they find a lump and they report to their doctor quickly. But the hallmark of diagnostic study is the mammogram. Mammogram is very widely available in the Western world, not necessarily in our part of the world, in Nigeria or Africa. Things are improving, and we hope it will keep improving. Other diagnostic study that we do is ultrasound and sometimes MRI. The mammogram has improved, the technology has improved remarkably, and recently they have a way to use artificial intelligence after you've done your mammogram to kind of give you the risk, your lifetime risk of having breast cancer. So this is a new thing that we are watching closely. Next slide, please. Now, the guideline has been changing on and off depending on which one you read, but this one on the slide basically explains what we are doing. By the age of 40, we want to start screening yearly. Definitely at the age of 45, we wanted to do yearly mammogram. 55 and older, there's a question of maybe you should do it every year, maybe every other year. I insist that my patients should do it every year. In high-risk women, at age 30, you got to do mammogram a lot earlier than waiting to be 40. People with high risk have a lifetime risk of cancer about 20% or greater. And there are several ways of calculating your risk. Next slide, please. Now, I just throw this slide in. It's a little bit busy, but on the right side, that's a typical inflammatory breast cancer. So this one just presents like an angry breast, hot, inflamed, red, and that's what we call inflammatory breast cancer, which is very, very dangerous with high mortality if you don't treat it in time. On the left side, it just shows you the progression of breast cancer to a full development and metastasis. I'm not going to go too much into that. Next slide, please. Now, this is how you identify breast cancer with imaging. The one that is most important is the one on the right, the mammography. You see all those cloudy area with microcalcification. That is definitely cancer. That's how we know it. And the MRI in the middle also show you the arrow point to the breast cancer area. The ultrasound on the left, you have to be really adept at reading ultrasound to pick that up. But mammography and MRI, even to lay people's eye, they can say, oh, this doesn't look right. This looks like an abnormal breast. And you can see that that's breast cancer. Next slide, please. Now, there are so many stages, there's several stages of breast cancer. There's many ways of staging breast cancer, but the simplest way is to just say stage 0 to stage 4. We use the size of the tumor, whether there's node positive or whether it has metastasis, it's called TNM. The other way to do this is to check whether the hormone, after you remove the cancer, the pathology will study the cancer and say, oh, it's hormone positive or it's hormone negative. So we call ER, PR, HER. So hormone negative, triple negative cancer are very bad cancer. Hormone positive cancer are a lot easier to treat. But this just gives you a vague idea that not all breast cancer are plugged together. We'd like to see them in stage 0, 1, and 2. Once you get to stage 4, that's bad news, and the mortality rate is high on that. Next one, please. Now, what do we do to treat? In the olden days, when I was first starting to practice surgery, you have breast cancer, you're scheduled for mastectomy. Mastectomy just means you remove the whole breast. We hardly do that anymore. There are still indications for doing mastectomy, removing the breast. But most of the time now, we do what they call breast conservative therapy, surgical therapy, what we call lumpectomy. So if you have a lump in your breast that we think is cancer, we just remove that lump together with normal rim of regular tissue. And then we may have to do axillary dissection, but we don't do full axillary dissection anymore. We do what they call sentinel lymph node dissection, where we just take the lymph node in the axilla that is kind of gatekeeper to the lymph drainage. So things have changed quite a bit, but when you do a lumpectomy, you have to add chemotherapy and radiation therapy. Nowadays, immunotherapy is becoming a big treatment right now. So those are the way we treat cancer. Surgery is still the mainstay of treating cancer, because once you take the tumor out, the residual tumor that you may have but you cannot see can be treated with radiation therapy or chemotherapy and immunotherapy. So there are algorithms for deciding on which of these treatments you will use. The medical oncologists and surgical oncologists have a way around how to advise you. But before you do any of this, you got to explain to the patient the pros and cons of the treatment you are recommending. Next slide, please. Now, well, I just want to throw this in because during COVID-19, there was a lot of treatment delay, mainly because of social distancing and limited healthcare resources. So we see a big delay in treatment, and people were presenting after COVID at a late stage of their cancer. But thank God the pandemic is gone. But like I always say, Another pandemic is only a few years away. So we will get another pandemic. It's only a matter of time. Hopefully, we'll be ready for the next pandemic. Next slide, please. Now, what are the risk factors? Okay, I already told you that female are more likely to get the breast cancer. The male ratio is only 1% of the population in this country. In East and Central Africa, 6% of the cancer have breast cancer. So as we all age, the incidence of all cancer increases. So it's the same thing with breast cancer. Race and ethnicity, the Caucasian race has a higher incidence of breast cancer, but unfortunately, when the Black race has breast cancer, it is the more dangerous one, the hormone negative one that affect them, and the mortality is a lot higher among the Black population. Obese women have a higher incidence. For some reason, and I don't have a good reference for this, they figure if you are very tall, you have a higher incidence of breast cancer. Same thing with exposure to ionizing. If you had radiation as a young people in the olden days, they used to treat acne with radiation. We find out that those kind of people end up with breast cancer more. Of course, family history. If your family history is positive for breast cancer, the chance of you having breast cancer is high. Benign breast disease, if you just have cyst or adenoma or the simple thing, and you keep having breast lump removed, but it's not cancer, a higher incidence. Well, in our diet, in the Western world, we have high fat diet, and that will increase the incidence of cancer. Now, the people that have been treated with the birth control pill, menopausal hormone, there are some argument that it may increase incidence of cancer. That's not been clear. Sometimes they will say yes, sometimes they will say no. Now, if you have your menstrual period at the earlier age, like below 15 years and below, you have an increased chance of developing breast cancer. If you also have a late menopause, there's also increased chance of breast cancer. Now, if you breastfeed and you are pregnant, if you are nulliparous, that means you never have any children or you have a child very late in life, there's a chance of breast cancer. But if you have your pregnancy and you did breastfeeding, your chance of breast cancer is low. One thing we can easily control is our physical activity. Lazy people like Sangodeyi who have increased breast cancer. So physical inactivity is bad. Alcohol intake and tobacco use are all bad. There's some genetic thing that we call BRCA1 and BRCA2. Certain people are genetically predisposed to having breast cancer, and we have a way to check that out. And if you are BRCA1 positive or 2 positive, we will do a genetic counseling as to whether you want to have prophylactic breast removal or definitely more earlier mammogram is very indicated. Next slide, please. Now, so how do we prevent and reduce our risk? Stop drinking alcohol. Be like Dr. Oye that doesn't drink alcohol at all. Do not smoke cigarette just like Dr. Oye doesn't. Well, I do drink alcohol, but to moderation. But like everything we all know, more fruits and vegetables, increase your physical activity. Some people, once they know they have a high risk of having cancer, they just say, take the 2 breasts out and give me an implant. We've known about some actresses that have done that, that are very well publicized. Next slide, please. Now, you can get information with these 2 organizations, komen.org. You can get a lot of information from breast cancer. For breast cancer, the same thing, you can go to cancer.org, and then you learn a lot more. Next slide, please. Yeah, I just want to show some of the celebrity who has already had breast cancer. Olivia Newton-John, Nancy Brinker, Judy Bloom. If you pull and I think you can, Nancy Reagan is another one of them. If you can read that, that is straightforward. So next slide, please. Yeah, so just like I said at the beginning, breast cancer awareness is not just in October, but 12 months out of the year. Pink looks good all year round. Next slide, please. Thank you for listening. Questions? Anybody have questions? Dr. O, you are muted.
Dr. Sangodeyi.
Yes.
Can you hear me?
Yeah, I can hear you now.
Yeah. Number one, thank you for the very insightful talk. When we talk about diagnosis, and we know mammography is the gold standard, you had indicated. Nowadays, with ultrasound technology and the possibility of using AI to back up the ultrasound, I think we may be up to something there because it may be a little cheaper for rural communities worldwide for one to go and use the ultrasound. But AI-backed technology, and see how that may be able to help diagnose some cancers a little earlier than later.
That is a very good point. Yet AI is doing a lot that is amazing to me, and then it's now predicting risk after I do mammogram. But ultrasound partner with AI would probably be the next thing, because in the developing world, mammography may be too much. But it's only a matter of time mammography will be widespread use if we manage our resources very well. Thank you very much, Dr. Oye.
Thank you.
And did you say mammography would be widespread use, or?
Yeah, I think so. I mean, the price is coming down. We have to find a way. I hate to use the word manufacture, but we have to find a way to be able to manufacture it and use it in the so-called world. There's enough money. I mean, compare Nigeria, for example. There's no reason why we should not have mammogram, at least in the regional area, like about every state or every big city where women can go and have their mammogram, or even have mobile mammography to drive around. So these are the kind of thing like Dr. E is trying to help develop infrastructure in Africa. This Dr. O, like you, these are the kind of thing we need to tell our so-called leader to kind of invest, because we see cancer of the breast very late in Africa. It's so sad.
Yeah, we need to do better. You're right. We actually, this was about 10, 15 years ago, put money together. We sent an MRI to one of our first ladies, I won't mention names, and sorry, not an MRI, mammogram machine.
Yeah.
Till date, we don't know what happened to it. It was not.
That's right.
So I'm going to call on Dr. Ronke Ogunleye, kindly unmute. But that was in the days when we didn't know how to navigate. We navigate better now in Nigeria.
Yeah. Navigation is important. You need to know who you're talking to. You got to follow through. You can't just dump the machine there and run away. You got to be able to work with it.
Exactly. We've grown.
Yes. Yes.
Dr. Ogunleye.
Yes, ma'am. Mine is more of a whine than a question. Let me ask first, though. Do men's scrotum undergo the same type of examination that our breasts undergo? I mean, how are they screened? Do they press their scrotum on a machine to see if there's any growth in there, sir?
Okay, so you're talking about testicular cancer?
Yes.
Oh, okay. For testicular cancer, I mean, it's so easy to examine your testicle as a man, and then when you go to your doctor, they should do testicular exam, not necessarily every time you go, but at least once every 3 months to see whether there's a lump there. If you start having pain or swelling, you need to let your doctor know. They don't do the diagnosis for testicular cancer. Is ultrasound can easily pick that up. We don't do mammography for that. So just ultrasound of the testicle is all we need.
So if men had breasts the mammography won't be as painful as it is today. They would have developed a machine that will scan it really quickly, painlessly. I think that's the reason we have such a widespread case of breast cancer, because it's painful, especially for women with dense breasts. Every time I go for a mammography, they tell me it's inconclusive because of denseness.
Yeah.
And right now I'm undergoing HRT, and part of the side effects is engorged breast. Well, I don't know if I'm using the right terminology.
That's right.
But it can be painful. So I'm even afraid of even thinking about mammography right now. Just to think of it gives me chills.
Well, people with dense breasts, we always recommend MRI. But unfortunately, some insurance just will not approve it until we've tried to do a mammography first. But MRI would be the ideal for that. But yes, many of my older women, or actually young women, always complain about pain. So it's one of those saying that's no pain, no gain. I mean, it's a fact that yes, the procedure could be painful, but I'm not sure whether things have improved with regard to reducing the pain of mammography. But I don't think that should be enough reason to not do mammography. But MRI for dense breast is very well recognized.
Yeah, I think they should have made a better machine before thinking about making Viagra. Sorry.
That's okay. So we need to work on that too. That is for the younger generation to figure out how to reduce the pain of mammography, or find a different mode to use to diagnose this early breast cancer. But dense breast is always a problem. Even so, we supplement with with the ultrasound and MRI. Yes.
Dr. Shannon, I have one more question for you.
Yeah, go ahead.
I suspect in the Niger Delta area of Nigeria, because of the pollution of the oil pollution and the waters have been contaminated by many of these drug company, oil companies, we're finding that persons that the water supply consequently may be contributing to some extent, don't know exactly, into what persons developing reference to cancers, including breast cancer. The question is, what kind of epidemiological studies can we do to better appreciate if there's a direct link between our environment and breast cancer formation in rural developing countries?
I mean, the role of environment is so high, is so great in many disease development. So that would be a very good study that one can do. I mean, obviously, the first thing to do is to kind of figure out, maybe have a registrar for cancer in that part of the world and correlate it, kind of look for carcinogen in the water that they're drinking or bathing with, and then you may be able to identify why or what. So that would be a big study, but that's a study that could be done at the right time. So I'm glad you mentioned that. Environment is so important in a lot of diseases.
So I'm going to come back to the MRI mammogram question and comments, but Madam VP, that's our, co-founders of NAPAC, kindly unmute and ask your question.
Thank you, Doctor. Looking good.
Thank you, ma'am.
Dr. Sangodeyi, thank you for your presentation. I have two questions. One of them maybe reference to what Dr. Ogunleye asked, but specifically my question is, in your demographic analysis, you said the white Caucasian are more predisposed to breast cancer, at least the female, but that when the Black people get it, it's more aggressive because of the negative, yes, more negative hormone or something like that you mentioned. What is the antecedent? Why, I mean, have they identified why when Black people get it, it's more aggressive? Is it for...
Well, we don't really know that. I was trying to do a study that got aborted. where I wanted to see, when I was in my degree, I was doing a study to see the hormone receptors among Nigerian black vis-a-vis American black. But that study never got anywhere because I ran away from my degree because of some issues. So, but to answer your question, I don't think we have a good way of answering that. But what everybody always says is that the black doesn't have clear access to the health care as easily as the whites. But that's kind of baloney argument. But it's true to some extent, but that cannot explain all the reasons. Why do we end up having more hormone negative breast cancer? So that may all be related to genetics. We don't really know that. That's something that we need to study.
Well,
Is that your picture? Is that your picture I'm seeing on the scene, or is that AI generated?
That's
no,
a picture. That's
that's
her.
me.
Oh wow, okay, I didn't know that. Okay, I'm
Yeah,
sorry.
yeah.
Uh,
So, but my connection with that question is with what Dr. Ogunleye asked. Could it be that the density of black people's breast, could it be that that uh, is one of the reasons why maybe early detection is not possible until it becomes aggressive? That's just a thought. My second
yeah,
question,
but
yeah,
let
go
me just
ahead.
comment on that. That is very interesting that you say that, and then, but that's something that we can easily find out a little bit, because we know um, people. I always say, I don't want to insult anybody, but we're a little bit thicker than the average white, so which we men also like. So, so, but I'll check into the density vis-a-vis racial differences with regard to density of the breast, because that's something I do not know.
Okay. So my second question is, once people go through this the treatment, cancer treatment, why does the regression happen? Like after 8 years or 9 years, for some people it comes back even more aggressive and now metastasize all over the body, even something that wasn't there. Is it
Yeah,
that the early intervention was not completely done, or does it have to do with people who did not? Even a couple of people that I know, they had the breast removal. So, but it came after some time.
yeah. Well, that's interesting. Well, that's the $1 million question. Why does cancer comes back? So even when you do mastectomy, there's still some cancer cell hanging around somewhere in the body. And for some reason, when your immunity decreases, it can act up 10 years down the road, 12 years down the road. We see that all the time for all cancer. But it is still very interesting that if you can catch cancer of the breast early at a very early stage and you do all those treatment that I mentioned to you, the chance of recurrence are very low. It's not 0%. So, but 10 years down the road, you can have recurrence. And then if you have breast cancer on one side, your chance of having cancer on the other side is also high. That's another risk factor. So that's why somebody with breast cancer on one side must continue to be followed regularly for possible cancer on the other breast or in the same breast. So yes, metastasis do happen, and it's just one of the $1 million question. We don't know why it happens, but when you think you cure cancer, there's still some little cell that is hanging around somewhere in your body that we cannot detect by all the technology we have now in PET scan. So down the road with your immunity lower, you can come back. Yes.
So would you then recommend that to in prevent as a preventative measure, people who have had that experience should probably check in every 5 years, or I mean, how frequent or how often should they
Yeah,
you know?
they should once you've got cancer, that's why the medical oncologist will follow you up forever for every year. And
I
there's
see.
medicine that if you are hormone receptor positive, there's medicine called tamoxifen that they give you And the argument as how long should you take it, 5 years or forever? Nobody has really settled that. But tamoxifen is one of those hormonal receptor antagonists that help suppress development of breast cancer down the road. But yes, I would recommend yearly follow-up with oncologists to check this, or your
Thank you.
PCP, whatever. Yeah.
Thank you. Now, my last question, and I'm not asking this to be funny. I'm just
That's okay.
curious.
That's okay.
Because in terms of body parts, I think men also have breast. So
Yes.
why is it that men don't get breast cancer? I'm not wishing it for men. I just want to
I
know.
understand.
Okay.
Yeah, we do get breast cancer, but it's like one out of 10 cancer of the breast that we see in US is male, and in East and Central Africa up to 6% male. But why? Because we just don't have as much breast tissue, and it's an hormonal interplay. We don't have the estrogen, as much estrogen as women have. So it's all related to the hormonal status. That's why we don't get breast cancer as often in male. Plus, the breast tissue in male is a lot less than in female.
Thank you for the education. God bless you.
Very, very good question. I appreciate that. But this density thing is very striking to review whether we African American have higher density breast than white. That's something I can easily research.
Thank you. Thank you so much. Madam VP, those were loaded questions, and thank you for asking them because it accorded us the opportunity to learn more. Thank you. Dr. Izugu,
Good.
kindly unmute and ask your question.
Okay, thank you so much. Thank you for that wonderful presentation and the education.
How you
My
doing, doctor?
question, yes, my question I have to really try to link this to a heart problem and see your comments on that. When ladies, when they go do mammogram, some of them, of course, get calcification. Can you comment on them for the arterial calcification and highlight the need to also look into cardiac issues if that's the case?
Good. Well, I was
Dr.
asking.
Dr. Izugu is a cardiologist. I think you
Yes,
were
I
asking
figured
that.
I figured that. I figured that out.
It's, it's our
it is
cardiologist.
okay,
Um,
good. And I'm going to turn this question to you later on because I was asking my cardiologist, Dr. Baguji is an older guy, and he's my cardiologist. And I said, good, what must I do? How do I prevent cardiac disease? What's the best test? And he told me, oh, just stress test. But then I saw another younger cardiologist who said, no, the classification of you have to do your classification score. So I'm kind of confused. So to answer your question, I think the classification score of your coronary is very interesting that we should all have, at least I don't know at what age you as cardiology would recommend we start measuring a classification score. But I'm not sure whether there's any correlation between the microclassification we see in the breast vis-a-vis the classification in the coronary artery. But the question I'm going to turn to you is, what is the best way to detect early coronary disease? Is it stress test or is it calcium measurement?
Okay. Let me come back. Thanks for that. So the for the breast mammogram, your regular calcifications not really, it doesn't relate to heart tissue. However,
Correct.
the calcification of the blood vessels in the breast, if let's say the calcification says is a breast arterial calcification, then those patients have increased risk for coronary disease. And so if that's reported as such, they should get evaluated from cardiovascular perspective, not just the garden variety breast calcification. So that's why I was bringing that issue, just in case you may get a mammogram and get such a report, not to ignore such findings. Okay. Now, in terms of part for evaluation of coronary disease, calcium scoring, and I'm going to explain it. Calcium is like a body way of trying to fix a broken part. So when it comes to the blood vessels, when there's a crack already, the body tries to calcify to fix that. So when we see coronary calcification, that means you already have coronary disease. There's no question about that. Now, you can also have what we call very soft plaques, which are the ones that can actually rupture and give heart attack, and they are not calcified, and you're at risk. So you find that screening at least the lipid profile, getting what the lipid cholesterol profile becomes extremely very important. And when you get a patient cholesterol profile, and let's say now there's equivocation on whether they should be on a cholesterol medication, then such patients, to help them make a decision, coronary calcium scoring becomes important, because if that score is over 100, they will benefit from starting therapy because they already have coronary disease. So that's how I would approach such a situation. But you can actually have a calcium score of 0 and still have a heart attack, especially if you have very soft plaque. Yes.
Correct. I see. That's interesting. That's interesting. But I think what I learned from what you're saying is that I need to let my radiologist give a report. It's not just to say you have microcalcification. I want you to tell me, what does the vascular status in the breast look like? Are they calcified? In which case, I got to tell my woman, yeah, you better go do some cardiac workup. Yeah, that's good.
Exactly.
That's very important. Good correlation. I thank you very much for that.
Thank you.
Fantastic. Dr. Sangodeyi, your presentation
Yes.
was amazing. It was
Well,
straight to the point. You spoke English. We understood you.
You think I was going to speak West Virginia Illy language?
Exactly, it's possible. The medical lingos and all of those. And
Yeah, you don't know that.
we totally understood. My audience understands, and we're grateful.
Good.
Thank you so much.
Good.
So I
Thank
want to
you.
ask you some questions on
Sure.
mammogram and MRI of the breasts. We know that screening is important. That's hands down. But there has been, different advices on when to start, how to screen, and what to screen with. Initially, it was suggested, or we used to do mammogram starting at age 40 every year. It was yearly mammogram. And then the medical colleges went schizophrenic because, some colleges suggested that we should start later at 45 or even 50, and it should be every other year to reduce the exposure to radiation. And they came up with this. They said because there are some studies that showed that the yearly exposure to radiation actually increases the risk of breast cancer. And so, like I said, the medical colleges went schizophrenic because there was no consensus, and we dealt with that for a bit. Our patients now are more, I don't know if they're more educated or more led by Google Doctor or Dr. Google, because so much
Dr. Google.
issue. Oh my gosh, Dr. Google is something else. And so they learn all these things. And so when there's no consensus, you're like, okay, let me just tell you what this college said, what this one said, what that one said, okay, what do you want to do? And it is not helpful for patients. So we have also seen advancement in the mammography itself, that we have
Yes.
newer machines that have less radiation or emit
Correct.
less radiation. We know that. So you said in your presentation that you suggest or you advise your patients to start at the age of 40 and they should screen yearly. But at the age of 50 to 55, something like that, you said they
Every other year.
can do yearly or every
Every
other
other
year.
year.
Okay. So can you please shed more light into this? Are there new developments? And before you go there, so you can talk about all of this together, we know that young breasts are dense, and young breasts we try to protect from radiation. It's why we don't start mammogram early, like in the 20s or 30s, but we're seeing breast cancer now that early, except in strong family history. So, what's your take on all of this? Now, help me make sense of this so I know how
Well,
to
it is interesting that the guideline has been changing. You are right about that. It's very confusing. Um, the consensus is not clear yet. We're still trying to define that. But obviously, it's very straightforward. In people with high risk, you have to start mammogram very early at the age of 30. Don't no argument about that. But in me, kind of medium risk or low risk, you start at 40. And I personally think you should start at 40 and do yearly until about 55. And after 55, you can do every other year. When my patient comes to me and they say, we don't want to do mammogram, I tell them the risk and benefit of doing this mammogram. If they don't like it, I don't force the issue because we don't really have a clear consensus. But my take, the way I recommend to my patient is, if you're high risk, please start at 30. And then 40, you start, do yearly till you're about 55. And then after that, if you want to do every other year. I've seen insurance company refusing to approve mammogram on 75 years old and above. They say, well, we don't need it. So it's up in the air. And that's just the way I practice, yearly 40 to about 55. And then after that, every other year. Yeah.
Thank you so much. I'm going to come back to that in a minute. I have our very own Oyin Chair of NAPAC, New Jersey. Have a hand raised. Kindly unmute. And
Can
she's
you tell me
also,
what NIPA means? What does NIPA mean?
NAPAC is the Nigerian American Public Affairs Committee or Nigerian American Political Affairs Committee.
Okay, I got it.
Yes, you need to join. And Onyi is actually on the school board also in New Jersey. Kindly ask your question.
Good evening. Thank you so much, Dr. O. This is such a timely topic. And and thank you so much to the doctor as well for, what you've been able to share so far. So my question is, when I said this is timely, I got a phone call from a friend, a very good friend from Nigeria, whose daughter, who is about 20, I think she's 23 years old. She was checking her breasts just a couple of days ago and found 2 lumps. Dr. O, I was actually going to, get in touch with you to actually ask questions because I haven't been in Nigeria in such a long time to even know what to do. So when I saw that you shared today's Medical Monday topic, I said, no matter what I'm doing, I must join. So her mom told her that to go to the hospital today. It's funny when you said that young breasts would try to protect. So for a young girl like this, I mean, of course, I don't know if it's cancer or anything else. She needs to get checked. What would you suggest that she does? Would she need to get a mammogram? Would she need to get some kind of scan? Because today she tried to go to the hospital. They are on strike. So
Gosh.
they wouldn't be able to do anything for her. So in the meantime, the mom sent me a message telling me that they said they're on strike. She should come back when they come back from strike, and they don't know when. So the mom said she knew of someone. The mom is a teacher. She knew of someone that the private school, brought to do scans for them. I don't know how they were able to do that by them visiting the school, but this is what she said. And she got in touch with the person, and the person gave them a prescription for Lexi-Tumotox. And this Lexi-Tumotox is anti-mutagenic, antimicrobial, anti-tumor, and anti-carcinogenic activity. And they list the different things that it does, which is supposed to be anti-tumor and is supposed to help in elimination of abnormal growth, and supposed to support the alkalizing the body fluid. But for a young girl of this age, I'm sure in America we will probably know where to direct her. It really, she's the only child. And I just, first of all, I don't even know if you will have any any leads for me to tell this family in Nigeria, or what can she do? Finding the two, because I asked her a very detailed question. She said it's not just one. She found two, like two different kind of swollen lumps in her breast. Thank you.
Yeah, usually
I want to
with that.
compliment the girl.
Okay, go ahead.
Go ahead. No, I said I want to compliment the girl for even checking the breast and for letting her mom know. I'm going to defer to you, Dr. Sangodeyi.
Okay. Yeah,
I'm
usually,
sorry, sir. Dr.
okay,
O, I'm glad that Onye shared this, because the threshold that has been said about age 40 is no longer effective. I've heard of cases of people younger. So when you talk about intervention, it needs to be soon, and I don't know.
No, actually, this does not even sound like cancer to me, but I'm going to let the expert handle it.
Well,
And then
yeah, all your questions are very well taken. You have to realize that screening is just what we call screening. It's not. We don't want to screen the whole population, so there's a limit to who you should screen, because otherwise your return on investment is very low. So if you screen everybody below the age of 40, the chance that you're going to detect cancer is very low. In particular, this young lady very likely just have what they call fibroadenoma, or just a cyst. It's very likely not a cancer, but I'm only saying that with only 90% certainty. I do not think it is cancer. What does she need? She just needs an ultrasound to see, because if it's a cyst, any primary care surgeon can aspirate it or just watch it. If it's fibroadenoma, they can either leave it alone or have a general surgeon excise it if it's getting too big. Very likely not cancer. I do not. It's not. If I see that kind of patient in US, I will not order a mammogram. I will just order an ultrasound and go from there. So I don't think. What the other thing that the young lady mentioned about this, or you mentioned about this stuff, I forgot the name of it. I don't know anything about it. It's probably from Korea, from China, or something. So, yeah. I don't know anything about that at all. But they should not over 3 days. They should not get too hyper about it. But an ultrasound is all they need, which I'm sure they. I mean, Dr. Oye can tell me whether it's easy to get ultrasound in Nigeria or not, which I think it is. Dr. Ye has a portable ultrasound that he takes to Nigeria all the time. So just ultrasound, if it's probably going to be a cyst or a fibroadenoma. We see that a lot in young girls.
Okay.
Yeah.
Thank you so much.
Before we go on, I just want to say, and Dr. Izugu, thank you so much. On this platform, we do not establish patient, physician, or physician-patient relationship. We are here to, just give sound education and from what we know in medicine.
Of course.
We are not establishing care.
Yes.
Correct.
It is important that I give that disclaimer. Again, Dr. Izugu, God bless you. Dr. Oye, go ahead.
The first question is accessibility. If there's a strike in Nigeria and a patient cannot get a mammogram, the question would be, what part of the country are they located in, number one? And number two, like Dr. Shangri mentioned, for a young person that age, it would be important that it would be less likely that be something aggressive, less likely. It's not impossible, but less likely. So it's more likely fibroadenoma, like you mentioned, or a cyst. Again, so an ultrasound would be a good test to do, and most ultrasound technicians in Nigeria should be able to do a good ultrasound to at least figure out that area in question to see if it's something to worry about. And they can get an ultrasound anywhere in Nigeria, even if they're on strike. You have some private labs that do ultrasound. I think that should not be a problem. Again, I don't know exactly what part of the country you live in, but that would be my first test. I would also not be in a rush to start taking medications, not knowing what side effects of medication would be for somebody where you've not even established a diagnosis. That may be almost dangerous.
Yeah. Thank you
Thank you
so
so
much
much.
for those comments. And yes, this girl, 23-year-old, it does not seem like cancer. It's probably not cancer. Um, it could also be fibrocystic breast changes. We don't have the whole history. We don't know if it's painful. We don't know when a menstrual period.
She said it's painful.
It's painful.
Yeah.
It may not even be fibroadenoma. It may be fibrocystic breast changes, which occurs with menstrual period. And she will see that, after the menstrual period, um, it would decrease or even go away, and it could occur again. Like Dr. Oye said, and I think Dr. Sangodeyi would agree, the three of us don't know what this Lexi talk is, and it really is probably not a good idea. An ultrasound does not use radiation. So that young breast will not be exposed to radiation. For rest of mind, it's important to get an ultrasound just to, for the peace of mind of the mother, the parents, and the girl herself. But the three of us, we won't go crazy over this. So it doesn't look like it.
Thank you so much.
Did I answer your question?
Yes, it did. Thank you very much.
Fantastic. You're welcome. So, Dr. Shagunde, yeah, I'm back again.
Okay, good.
So, does stress, lack of sleep, do they have anything to do with this increased incidence of breast cancer?
I would say yes, but I don't have any study to back my answer. But stress is bad for everything, for everybody. Just like you said at the beginning, we doctors should relax and rest and go to Maryland and party more often and
Yes,
eat more and eat more of that suya stuff. Yes, but
exactly.
seriously though, yes, stress is bad for all of us. Yes.
You're so on point. Honestly, I can't say any more than that. You are so on
Yes.
point. And, people may think, oh, they're joking. No,
No,
this is
stress is
actually
bad.
medicine. To be with people you enjoy, that you relate to, enjoy yourself is actually very healthy. So you also mentioned in your presentation that age at menarche, if it was late before menarche means when somebody starts menstrual period. So the age somebody starts menstrual period, and if it's late, what do you call late? What age is late
Uh,
to start menstrual?
okay. No, I said if your menopause is late and if your menarche is early. So
Oh,
by
menarche, if starting period is early,
yeah,
like
early, like if you're
eight,
below
eight, nine,
15,
9-year-olds. I've seen those.
yes, 10, 11 years, 15 years and below. That's what I call early menarche, early first period. Menopause, yeah, if you're still menstruating up until 55, well, that's dangerous. That increases the risk of cancer of the breast.
Yeah, the average age of menopause is 51, as we have.
Correct.
So, okay. Thank you for that clarification. Now, I
Yeah,
want to
yeah.
go back to the testicular
Okay,
that
okay.
Dr. Ogunleye mentioned. In primary care, because I'm in primary care, I'm a primary care doctor, I'm a family practitioner, we actually would check the testicles once a year during physical
Good.
exam is when we do. And we do it actually in children. Unless an adult man has concern, I don't check their testicles. There's no standard for it, right? And we don't have a screening test like ultrasound or mammogram that we do every year or every other year or something like that. We don't have that to check testicular cancer, but we do educate our patients that they should check their testicles. And I actually will show them how to roll their hands like that, around the testicles to make sure that there are no lumps. And if there are lumps, they should come to clinic so we can follow it up. So it's when they find a lump or the testicle is painful that we actually, will follow. just to what we do in primary care is what I wanted to say. Because that's not a fair question to you. You don't see testicles.
Well, I do. I have quite a lot of male patients that I worry about. We pick up a few kinds of the testicle once in a while, but we don't. There's no routine test for it. But like every 6 months, a PCP or should at least check somebody's testicle.
Well, thank you for that. And thank you for being so well-rounded, for, also, going that far with your patients. And yes, indeed, men too can get breast cancer. It's just not as common.
Correct.
Yeah. Someone wrote here, because some people will write their questions in the chat box. So thank you so much for your very impressive presentation. The person wonders if you can expatiate on need for diet that minimize acidity, and secondly, the importance of sleep and stress management to reduce cancer occurrence. Oh my gosh, yeah, okay, I asked that. But this acidity thing, I hear that a lot, that alkalinize your body. Alkalinize your body. That's an excellent question. Please shed light into that for us. Thank you.
Well, I mean, we're talking about anti-inflammatory response to our body. Most of the disease that we're talking about and cancer, we always say it's all inflammatory progenics. And I'm not too sure about what diet you need to take to alkalinize your body. Maybe you can expatiate on that. But with regard to sleep and stress management, there's no argument that is very important. But one of the things I always impress on my patient is good sleep, drink a lot of fluid. I don't mean alcohol, I mean good water and everything, and eat a lot of fruits and vegetables. That's so critical to reduce most diseases that we just have to do that. Same thing with cancer of the colon. So if we eat enough fibers, that would be good. So I'm not too sure about what we mean by alkalinizing the body.
Well, I've seen it. I don't see any research that supports it. And I'm actually concerned when people are consuming things that they say they alkalinize in the body to prevent cancer, or, suggesting it to people who have cancer. So I will not be able to comment on that either, because I have to see the research and to even know what people need to do to alkalinize the body. It is not medicine. Yeah. Yeah. So, any other questions?
Dr. O,
Yes, go ahead.
there's a billion-dollar industry around alkaline water.
Yes.
And you know our people. When they want to sell something, they'll start circulating posts and memes around that, throwing that out there, hoping people will buy it. I think that's where that came from.
You're right. I see those alkalinized water. I have never tasted one myself. I don't know what it tastes like. Because I don't want to cause problems that don't exist inside me. Thank you for bringing that up. Dr. Sangodeyi, you have seen those, right?
Yes. Oh yeah, I've seen it in the cafeteria. They sell this big bottle of alkalinized water, PhD, So I see that all the time. Good water, healthy water. So I don't know. I'm not too sure about alkalinizing your body. Maybe it's something that we should look into, but I'm not familiar with it.
Yeah. Maybe we
Well,
should.
I drink a lot of it. It aids digestion. It's also easier to drink. But I think somebody on this forum said maybe it's too acidic or something that could thin your stomach. I don't know. Somebody said it somewhere. But when you taste it,
Dr. Bill of blessed memory.
Oh, Dr. Bill was the one who said it. Yeah.
Okay.
Of blessed memory. Yeah.
Thank you, Dr. AJ.
Thank you, Dr. Ajay. Yeah.
Is that previous lecture? Is that today? Or do you mean?
No, that was Medical Mondays family. It was
Okay, I got you.
regular on Medical Mondays, and he's now home with the Lord. He passed.
Oh, I'm sorry.
And
It's so resting.
well, medicine, we were trained not to say pass. He died. You have to say, I don't know, when I'm on Medical Mondays, medical I just want to speak English and not medicine all the time. So he was the one who said that. We need to
Okay.
look into alkaline water.
Yeah, he warned us about the pH levels and what we should be doing with it. Some boil it, which is not good. But what he said, we have to do more research and hit to the best ways to live better.
Yes. Thank you.
Okay. Thank you.
I need to look into that. We'll talk about that sometime again. Somebody posted something on that. Sister Florence says alkaline water, usually defined as water with a pH higher than 7, is often marketed as having health benefits, but the scientific evidence supporting those claims is limited and mixed.
Okay.
Thank you
Good.
so much for that insight. Thanks. We appreciate that. So, Onyi, kindly unmute.
Okay. Thank you, Dr. O. So, when you're talking about alkaline water, it just brought me back to when you and I spoke a few weeks back, and there was a particular tea. I forgot the name of that tea, and I just thought maybe it would be, a good time to kind of like ask question about that tea. To actually, I mean, I I think somebody was drinking it and they were able to see some kind of like a change. So maybe we can ask doctor
Tahibo
about that.
Sorry?
It's Tahibo tea. I've been
Tahibo tea.
drinking it
Yes.
too. Yeah.
Was it Tahibo? The name doesn't ring a
It's,
bell. I think was it Tahibo?
it's Tahibo tea.
Oh,
And
Tahibo. Okay.
Tahibo tea is actually a tea that has been very, very helpful to a lot of people that I know that have cancer or cancer in remission right now. And it was a patient of mine who came and shared with me that her father was diagnosed with esophageal cancer at the age of 83, 4 years ago. And the man refused to take chemo that was recommended. It felt it was 83, it's okay if that was the way he was going to die. She researched and stumbled on Taibo Tea Club because they say Taibo Tea on Amazon is not the same. So it's Tahibo Tea Club. And she got it, gave it to her dad. He didn't mind drinking it twice a day. And it's now 87. That was 4 years ago. His esophageal cancer is in remission. So the guy who is selling this is actually in California. And his dad was diagnosed with colon cancer, stage 4, was told to go take care of his home when somebody came to visit and brought the Taibo tea 30 something years ago. He was in his 60s then, he's now in his 90s. And colon cancer has been in remission since. And it was in stage 4 at that time. That was Taibo tea.
Mm.
These are that's what exactly what happened that I know about. So I'm a scientist. Research needs to be done. More people need to be exposed
Yes.
to it. We need to know that it's doing what it has done for others. If it's repeated over and over again, then it's doing what it's supposed to do or what they say it should do.
Yeah. Thank you.
Well, we're talking about diverging into cancer on this, I don't plan to extend this discussion too much, but I've had a lot of things about ewedu. I forgot what they call it. Jitu leaf. Is that what we call it here?
Yeah, jute leaves.
Yeah, jute leaf. Yes. So everybody that I know, my friend that have died of cancer of the colon, they swear by it, they eat it, they put it into the soup and all kind of drink, and they think it helps. So who knows? I don't know, but there may be any of you have any scientific knowledge about jute leaf helping. Maybe it's got some anti-inflammatory stuff that is preventing cancer. I don't have a clue.
Well, it is digestion. Anyways, does even whether if it doesn't prevent, that's a way to.
Yeah,
Yes.
we do.
I like it. I enjoy it. I enjoy the once in a while.
So
Well,
I have one more comment. Dr. O,
a minute.
if you can
Just
pardon
one.
me. Okay.
Yes, you will come on, but just one comment. As opposed to the alkaline water, ewedu will aid digestion because it's a vegetable. We encourage vegetables and fruits,
All
and
the
they
time.
aid digestion. Yes.
Okay, that makes sense.
Where did you get the table deal from, the tea?
I'll share with you of what I was sent.
Yeah.
I'll share with you.
Yeah. So my next comment is if someone has a lump and did a biopsy and it was inconclusive, and they did an MRI and was told by an oncologist that the lump need to be removed, and the lump was removed and they sent it to the lab and it was not cancer. Can that person still develop cancer, or can that lump come back? It's a big question in my head for years. And it's very scary. So it was not cancer, but then can that person, I mean, I guess anyone can develop cancer at any time, but because you've had that kind of situation before, can that come back?
All right.
Excellent
So
question.
the lump will not come back because the lump is gone. But there could be another lump that developed. It depends on the kind of lump. If it's like fibrocystic disease that, like Dr. O suggested, if fibrocystic disease come and go, you get another one somewhere else. So it doesn't mean the lump come back. It just means another part of your breast developed that. And if you have a lump and they did a biopsy and it's inconclusive, yes, it's best to remove it because then that gives you pleasure that I'm happy it's not cancer. Okay, so it doesn't mean you cannot develop cancer down the road. Just like I said in my lecture, one of the risks involved in having fibrocystic disease, fibroadenoma, what we call benign disease, you have increased risk of developing cancer because of you've had all these small cysts that is on your breast, and down the road you may develop breast cancer. So those kind of people need to be monitored more carefully. But if you have, occasionally we have cases that pathologists could not say for sure whether it's breast cancer or not. In that case, you should remove the lump just to be safe rather than just leave it there and say, well, they told me it's inconclusive. If it's inconclusive, it needs to come out.
Thank you.
Yeah.
Yeah. But note what was said, that there is an increased risk. It doesn't mean the person will develop cancer because they've had an adenoma, fibroadenoma, or they've had a cyst. No. It doesn't translate into that.
Just the risk.
It's just the risk.
The increase. It doesn't mean you will develop it. We're not saying that. You just increase risk. That's all.
Okay, thank you.
Yeah. So no anxiety. Yeah. Madam VP,
Good.
kindly unmute.
Yes, this Tashibo, whatever Takiki something tea.
You want to get some?
Yeah, but I don't have any thing. What is it? Is it?
My patient actually told me that her father still drinks it, been drinking it for 4 years, twice a day, and that she drinks it once a day. So I said, "You're my patient. You don't have cancer, and we do screenings." She said, Doctor O, it's for prevention.
Okay.
That's
okay.
okay.
My question.
I've been drinking it too.
Oh, wow.
Yeah.
Yeah, that's my question. Is Is it okay?
Yes, I
Okay.
drink it.
Okay. What? You didn't even tell me. What do you mean you drink it? How come there's problem?
Yes, so there is problem.
Well, I
There's a
think
reason. There's a reason. We were
Okay.
preparing for wedding and a lot was going on.
Oh,
we've got
okay.
to take things easy, man. There's
Okay, so
one
ship
person.
10 cartons to my house now.
uh-oh. No, I just want that suya. That's all I want. I don't want tabiti. I don't need tabiti.
Don't worry, we'll fix this. Yeah.
Okay.
So somebody just sent here the Taibo tea natural. See what she told me, because immediately it was in clinic and I'm just being totally open. What she told me was Taibo tea, and I went to my phone and I said, "Oh, it's on Amazon." He said, "No, no, no, don't buy it on Amazon. You want to go to the Taibo tea club." And where
Oh,
I don't, so I gave her my number to send it to me right away, because I'm like, okay, this is something that needs to be looked into, because, these are testimonies of people, and we need to see if it pans out.
Also, Dr. O, what about bitter leaf? Is that also anti-inflammatory?
Dr. Sangodeyi, where is Papa
well,
Mike? Is Papa Mike on?
Yes,
Because, um,
I don't have.
Dr. Oye, go ahead. I thought you were going to say something.
yeah, bitter leaf is been it's anti-inflammatory. It has been shown in some studies to have anti-carcinogenic properties. And again, the difference is we use bitter leaf in our meals, and the American companies have not actually bottled it or put it in tablet form, and they're selling that out as pills. So yeah, it does have some benefits, absolutely.
Yeah, that is true. They do have pills. One of our pharmacists on the platform said that she has the pills. But in my opinion, it's always better to go to the natural,
Original.
original. Yes.
Yes, that's correct.
Yeah. Because pills, tablets, they are important. We need them. But you do have to have fillers in order to make them into what they are. So when things like bitter leaf, one can get natural bitter leaf.
Yeah.
Yeah. Yeah. Any other questions? This has been amazingly robust. I've learned so much.
Dr. Shangade, one more final question for you.
Sure.
When a platform that you did mention that Black women generally tend to have more aggressive form of triple negative cancer because number one, they present late, and then maybe a genetic predisposition maybe. What can we do as a people to ensure that breast cancer, not apart from just the awareness, what can we do as people to ensure that we women generally understand that the breast cancer, we can do better at early detection? What can women do short of going to the hospital apart from the screening that'll increase their likelihood awareness generally for the average person who walks in the market in Africa who has no idea what's going on? How can we make this awareness more common to them so they're able to identify with this health hazard that potentially can kill them?
Well, I think it's basically education, public education, which we need to do a lot more. So I don't think we're doing enough of it. So with your foundation, with my World Health Mission group, with Dr. Oz, we need to just start finding a way to let people know. Go to churches, go to mosques, go to schools, and market women and talk and I mean, when I was in my degree, we had a big, I mean, they did a TV show on one of the news, and that with me and talking about breast cancer, and that kind of get the attention of the market women, and they all want to learn. And we went to all the big market, and the University of my degree make a publicity kind of a pamphlet and distribute and talk in the native language. So we need to start developing this kind of approach so that people can know what we're talking about. Yeah.
Yeah. Thank you so much. That is so true.
Education.
Yeah, it's educational, education. But when we're looking at places like in Nigeria, we just talked about there aren't mammograms and all around. Breast exam can be very, very beneficial. To do breast exams once a month, if the woman is still in the menstruating period, they should do their breast exams at least a week after the period, not before and not during. Because, like we just talked about, fibrocystic breast changes. If a young lady or somebody menstruating have fibrocystic breast changes, they're gonna go crazy when they start feeling lumps just before or during menses. So that's why they do their breast exams a week after. And when they do the breast exam, we can teach people how to do their breast exam to start with the clavicular bone, the bone right here, and just go with the tips of the finger and go down in circular motion all the way down to the breast, or back up, back down, back up, all the way around to feel for lumps. Because any lump that somebody can feel with the tips of their fingers, then needs to be investigated. And after checking that, they should check underneath the breast also, still with the tips of the fingers, and then go into their armpit, because the breast dumps into the lymphatic system. It goes through the armpit. So they should check under their armpit, still with the tips of the fingers, and make sure that there are no lumps there. Then they should squeeze their nipple. If there is any drainage, milky, bloody, it needs to be investigated. Then they need to go to the doctors. It's what I would, add on to what you have said, Dr. Sangodeyi, to do the breast exams. Every woman once a month, or if they're menstruating, to do it a week after their period, or at least a week after, not to create scare situations if they have to have fibrocystic breast changes. Breast exams have been very beneficial. Most women who have breast cancer actually finds their own lumps. Most is what research has shown. So, Dr. Sangodeyi, do you want to add something to that? Your camera is off.
Well, yeah, that's right. I just want to hide my beautiful, handsome face for a minute.
You know what? I didn't miss when you said you are the oldest person on the platform. Nobody will believe you, because see how you look.
Well, thank God. Yeah, I feel good.
Anyone on Medical Mondays can answer this. Does it look like the oldest person on this platform?
How old is he now? You open that can. You open that can.
Oh my goodness.
It doesn't matter. It's the fact is,
why do you want to know how old I am?
You cannot make that assertion without proof.
Okay, can you guess my age?
I will say maybe you're 78.
Good, you got it.
Okay.
Really?
Yeah, I am.
Wow. Madam VP, how could you
you are the first one that ever guessed my age correctly.
It doesn't look anything like 70.
They always call me 55, 56.
Yes.
No, that's catfishing. You don't do 55.
Okay, that's fine. So you are right. You got it correctly.
Thank you.
So you got the prize, okay?
Well,
yeah, but I think Papa Oye is older than you.
Yes, of
course. Who is Papa Oye?
Dr. Mike Oye. It's a naturopathic doctor who comes. Is our Papa.
Okay, I don't know him. Okay.
Yeah, but that's okay. You can co-grandparent Medical Monday. That means you're going to make the biggest donation.
All right, that's good.
I'm
Okay,
going,
good.
I'm going to say though that you don't look anywhere near 78. So Dr. Omotosho, kindly unmute. Thank you.
Oh,
And ask your question.
Okay, good evening. Can you hear me, please?
Yes.
Yes.
Oh, Dr. O, thank you for these, today's gathering. And I will say, Dr. Sangodeyi, thank you so much. It's interesting that at the first try, somebody guessed accurately how young you are. And
Thank you. I'm
that is,
happy for that.
yeah, that's right. So that is making me to come with a correlation with what good
But
president here just
you
said.
are not showing your face. Why not?
Because I'm in a
All right.
position where I
not only
cannot
that,
have
he
You're
has
good.
fake,
You're
he
good.
has fake beard. Dr. Motosha has
So,
fake
You're
beard.
good.
so my question is, will you consider what our 79-year young president is saying about Nigeria? Will you consider it a benign cancer or a chronic cancer about trying to invade Nigeria?
No, we don't want him to invade Nigeria, period. Okay.
No, that's not a question for Medical Monday. We need to scrap
Well,
that.
not only that, Dr. Motosho, I'm glad you are a physician yourself, so you can answer that question for us. Because, like Madam VP said, it's really not a question for Medical Mondays with Dr. O. We just want to make sure that you prevent cancer.
Well, the reason why I'm asking it is simply because a good doctor, Dr. Sangodeyi, doesn't really understand what NAPAC is for. And that's why I'm bringing it up, so that you can link the answer yourself to NAPAC and then encourage him to join and at the same time be able to educate him further. Thank you.
Thank you. Thank you so
All right.
much.
Thank you,
That's an
Dr. O.
excellent point. Dr. Motosho made an excellent point. NAPAC, we have realized that politics is what runs every area of our lives. And if somebody does not know that or believe that, this present time we're living in would help us understand that politics, shapes every area of our lives. And it is important that everybody makes their voices heard, that you go out to vote, register to vote, and go out to vote. Part of what NEPAC does is to do that education, that please register to vote. NEPAC is non-partisan. But we would encourage you to go out to vote and vote your conscience, because whoever you put in office is going to dictate the decisions that affect every area of our lives after they get in office. That's what we do as NEPAC. And yes, Dr. Sangodeyi, you should join.
Okay, I'll think about it.
Okay, thank you. So now this has been amazing. And when we talked about Nigeria, I actually embarking on a mission trip to Nigeria in December. And part of what we do when we do the missions, this is going to be a comprehensive one. Our nonprofit organization, Global Vision Foundation, is actually partnering with NAPAC Foundation, the health component. See, we just talked about NAPAC. We have different branches. There's NAPAC Foundation that is a 501c3, and we're going to partner to do screenings, blood pressure, blood sugars, eye, dental, ENT. We'll do cataract surgeries. We will do, surgical interventions if needed. We've done pap smear before, and I just talked to somebody today to see if I can get that group again to come on out to do pap smears. We do breast exams, but we don't have somewhere to do mammogram or anything like that. This conversation tonight has reawakened my awareness and my need to see how we can intervene there and have somewhere where people can screen, have mammogram. I will look into that, when I get on ground or before then. So this Saturday, we're having the first ever fundraiser. We've been doing this since 2003. We've never fundraised, but we're having our first fundraiser this Saturday at Laurel at, on Main Street. If you're interested in coming, let me know. It's going to be at a Nigerian restaurant. And we'll be glad to have you. Apart from coming for good food, you're going to, also be able to interact with a lot of people and, just have a good time together. It's what we plan on doing. I'm trying to get again the specifics for that. But before then, before I revert back to that, Dr. Sangodeyi, if you please come back and give us your closing remarks, what you would like us to take home, the take-home message, that would be fantastic.
Well, the take-home message is that we need to do a lot more in our continent. I'm so happy that you and Dr. Oye and the rest of the group, your NEPA, are doing quite a lot. And we need to really educate our people how to do breast exam, how to do early diagnosis, not to ignore lumps in their breast. And we should all know that this diseases is no more death sentences in the Western world. We need to carry that to our country so that people don't die needlessly of breast cancer that could easily be treated nowadays. Thank you very much.
Thank you so much. Thank you. Appreciate you. Dr. Oye was there with us at our last medical missions in Nigeria. And is going to be there again this year. We don't play, we don't joke. Dr. Oye is changing lives. He has an outfit in Ikeja with a C-arm. People who come in that they have blood clots or stuff like that. They suck it out. I mean, that's the only way I can explain it. They suck it out and they will be out of there within an hour. So I thank God for him. I thank God for, every one of us that partner together to just go back home and give back. There's a lot of need back home, a lot. Somebody is asking me on how to join NAPAC. You go to the website, NAPAC, NAPACUSA.org, and you will see the join. So on Saturday, we're going to be at the Sky Vibe, SKYVIBE, on Main Street in Laurel, Maryland, from 4 p.m. to like 8. Come for free food, good music, and hang out.
Any suya?
There'll be suya. But you're going to get yours already. Don't worry. You're going to get it. Right after this talk, I'm calling you before I come, Madam VP. Madam VP, you have your hand raised. Kindly go ahead, take the floor.
All right.
Madam VP, go ahead.
Yes, ma'am. My question is, somehow Dr. Motoshaw has escaped presentation on this Medical Monday. Somehow. So I'm calling him out. You need to find a topic for him to come and share his deep knowledge. Yes. Dr. Motoshaw, Ento Monilon Sheni. So
Dr. Motoshaw, you heard that. So I'll be following up. You know me. I will follow up as I'm instructed.
Dr. Mutosho, you can talk about how invasion of Nigeria will impact our stress levels.
I love that. I love that. So, Dr. Motoshaw, we'll be looking forward to that. The NAPAC link to join NAPAC is in the chat box. Again, it's napac.org. And the Sky Vibe on Saturday is at 352 Main Street, Laurel, Maryland. It's posted in the chat box also. Till we meet again next week, please stay safe and be happy. Make it on Saturday so we can